And this was a model that was used and has been used, a similar one, in most of the other studies. So let me explain this. This is going to be, well, it's a cohort model or a Markov model. We're imagining a cohort of individuals. For example, suppose you've got 1,000 individuals who start in this state here. They're not cirrhotic, so disease is in an early stage, but they are HCV positive. Okay? Now, if you're able to clear the virus, you move them into this health state, SVR, sustained viral response. Essentially, the virus is undetectable 12 weeks after treatment. Another possibility is the patient is going to advance over time and may then get into a state called compensated cirrhosis. So basically, they are cirrhotic, but the liver is still functioning, not so well, but still functioning. If things go further, they can move to decompensated cirrhosis, where if they're going to survive, they're going to need a liver transplant. Also, once you reach compensated cirrhosis, you're at a substantial risk of developing cancer. So that's another possibility. And so we've got these are the different health states that are thought to be relevant to patients with this condition. And so what we do in this model is we imagine 1,000, it can be 10,000, but patients starting with the virus, positive for the virus, but non-cirrhotic. And we say, right, if we give them the current treatments, what will happen over the rest of their lifetime? Basically, what will happen is a few will have the virus cleared, maybe half of them, maybe. The rest will essentially progress through the paths here, ultimately ending up with death. We then want to compare that with what happens if we add in sofosbuvir. And of course, what we're expecting is many more people might make the move to the cleared virus because the drug's more effective, it's also easier to take. And so the real payback from improved treatment is fewer patients are going to reach these very unpleasant and very expensive health states. So, to run a model like this, we need what are called transition probabilities. This is simply telling us at what rate do people move from one health state to another. So, for each of these arrows, that is a transition. That's a movement between health states. And the arrow back in itself means that you started in the health state, and then after a time period, you're still in that health state. Okay? And so what we're expecting in particular is the new treatment should increase this transition clearance of the virus. And of course, if that happens, there's then fewer patients available to come through to these more severe health states. So for all of these arrows, we need a number, a transition probability, somewhere between 0 and 1. 0 means the transition can't happen. 1 means you are guaranteed in the next time period to move. So it's somewhere between 0 and 1. And for the clearance of the virus, data came from the sofosbuvir trials, and they're fairly small trials, sometimes single-arm trials, sometimes against an active comparator, and they were relatively small trials. Also, there was data from historical controls. So we had quite a good idea from previously what happens to untreated patients, because a lot of patients weren't thought suitable for interferon and ribavirin because it's a difficult one to take. So those studies provided some of the data, but there's a whole series of transitions here where any trial's not going to capture these because these are going to be largely future events. So for the trial, you may get data on some of these transitions, but for these more future events, you're going to have to go to the literature to get estimates. And so that's the case here. Is this all blindingly obvious? Do stop me or whatever if you want any clarification. Okay, I push on. So, drug costs. These were the costs for England. And so we've got the sofosbuvir or the telaprevir or the boceprevir. These treatments had particular costs. Costs of pegylated interferon, nice and cheap, just unfortunately doesn't work very well. Ribavirin, even cheaper. And so we're interested in the total drug costs. And so as you can see, adding in sofosbuvir, if you were successful in treating in 12 weeks, the drug cost's not too bad compared to, say, some other existing practice. A bit more expensive, but it doesn't look too bad. In the event that you have to go out to 24 weeks treatment, it's rather higher. But just the context was this: most patients, if they were getting treated, were probably in this sort of category previously. Pegylated interferon ribavirin cost about 10,000. And so now, almost overnight, the NHS is facing the prospect of not spending 10,000 on the treatment, but 37, 35, or maybe even 70,000 on the treatment. And this picture of a rapid change in expenditure repeated itself all around the world. And so there's not a single country didn't face a bit of a problem with that such an abrupt increase in potential expenditure. That was the treatment costs. There's also, as I said, health state costs. So just being in different health states has a cost. F0 to F3 and F4, these are measures of how much damage the liver has incurred, measures of fibrosis. If you get to needing a transplant, that's pretty expensive. Living with decompensated cirrhosis, quite expensive as well. Notice these costs are coming from the literature and are quite old estimates. 2006, 2001. Now all they did was then adjust them for inflation, but to what extent are these costs likely to be relevant in 2014 or something like that? It really doesn't like me going faster. Yes? Oh, I just spent 5 minutes trying to go forward.
to the model.
Oh, right.
You talked about the
transition.
The transition probabilities,
Mm-hmm.
but you did not explain how you apply these transition probabilities to the model.
Okay, sorry, right. Yeah. It comes of trying to cram, 6 lectures into one. Right. In this approach, a Markov model, you essentially it's a bit like taking a snapshot over time. And so you start time 0, and in the model you have everybody in the non-cirrhotic state. Then you roll forward, say a month or 3 months, depending on the condition, sometimes a longer period, and you say, right, well actually quite a good one here would be 12 weeks, 3 months, because the treatment's meant to last that long. In 3 months, how many patients are still in that health state where they started? How many have transited or moved to another health state? Then in another 3 months later, how many are in the different health states? And so you've got a series of, if you like, snapshots over time, and over time, fewer and fewer people are going to be in that starting health state. They're going to have moved to other places. And so that's how you're doing it. And you typically run the model for the patient's lifetime. So if you start with 1,000 patients, you let the model run until everybody's dead. Now, of course, this is, for the computer, it's nothing. I mean, it's just a blink, but that's what you do. Does that answer your question? I mean, there's a whole lot of questions. Where do we get the transition probability from? And that's when we take the trial data and we look at how many people are moving from one health state to another over time, and we turn that into a rate. Yeah.
Is such a closed model? Do you allow also entry to the model? For example, those who newly develop cirrhosis into the model?
Right. In the basic model here, in asking the question, should we add sofosbuvir in as a treatment to patients who are non-cirrhotic, we start with everyone there. If we then want to ask the question, what if they have cirrhosis? We just run the model again, but this time start with 1,000 people with compensated cirrhosis. So it is closed, but it does allow us to look at different ways of looking at it. You wouldn't start with 1,000 with decompensated cirrhosis because there's nothing you can do for them. Well, the sofosbuvir is not going to help.
Which software do you use?
Typically, these will be run in Excel. That's the most common one that's used for the appraisal committee that I'm on. But of course, there are other packages out there. But Excel's quite flexible, at least for Markov modelling, cohort modelling. Oh yes, sorry.
So that model is static model or dynamic model?
It's in the context of infectious disease, which of course hepatitis C is. It's fair to say this is a static model, not dynamic. Now, by that, we are not considering, or let's put it fair, the manufacturer who created the model, we then review the model and the results from it. The model is not considering prevention of transmission. Now, prevention of transmission may well be an important issue because a very large number of the people who are HCV positive in an English context are intravenous drug users, in which case they may well be more likely to transmit to other people than non-drug users because of sharing of needles and things like that. I have myself done a paper allowing for, not just me, it was lots of co-authors, but it sounds good if I say I have myself, but I was a small part in a paper that did a dynamic model, and what we actually showed was that there was important prevention benefit here, and it does lead to important questions about who to treat first, which I think we just touched briefly on Friday. Yeah, so this is a static model. And all the models for the succeeding directly acting antivirals, they've all been static, which is curious. It's childcare. Go on.
So, but in Excel, the dynamic model can also be built well in Excel. Or
Excel's pretty flexible. You might want something more specialized. You might want a more specialized package. The big distinction often in packages is whether it's a cohort model or it's an individual level model. Now, if it's individual level, something like Excel may not really be satisfactory. But for cohort models, so we've got our 1,000 people and asking what happens to the cohort, generally it's quite acceptable.